Hi, everyone. Welcome to today's virtual shadowing session. Tonight, we're going to be talking about internal medicine, hospice, and a question that I feel like is very important for future doctors to know about how to deal with the patient's death and what's the right way to deal with it. You can go to the next slide.
Next slide, please, Shani. Can you?
Yeah, I don't know why it's not moving.
Oh, there we go.
There we go.
So here are our future sessions. Next Tuesday, we're going to have a specialty spotlight with ophthalmology. And on the 8th is going to be innovation in medicine. And on the 15th of February, we are yet to announce it, but just stay tuned. We'll definitely let you guys know. Okay, next slide. This is our virtual shadowing group. Go to the next slide. And we're going to have 2 Q&A sessions, one in the middle of the presentation and one near the end. Also, by the end of today's presentation, not only are you guys going to access this session's quiz, we're going to reopen a quiz back from session 10. To know more about that, just wait till the end. We'll definitely let you guys know about how to do it. Before we continue on, Dr. Fowler, you got a couple words?
Yeah, welcome everybody. So good to have you all back. A lot of familiar names. We always appreciate you coming back week after week. We have a wonderful talk for you tonight. And also our talk next week, Dr. Preston Bloomquist is a terrific speaker, humanist, ophthalmologist, one of the smartest people that I know, with whom I served on the admissions committee at Southwestern for years, and you will really enjoy him. Try to make next week. We appreciate you coming back week after week. As long as you keep coming back, we're going to be here. We've continued to open some of the old exams so that you can get credit for previous sessions that you can go and watch. And we're doing that in part because we know now that admissions committees to healthcare programs are paying attention to online virtual shadowing hours. And so we want to be able to help support you in your mission to whatever your healthcare program is of the future. So just on a personal note, as well as speaking, I know for the working group, we really appreciate you coming back week after week. I think we've become friends with a lot of you as we chat each other up in these sessions. And so just welcome, and it's so good to have you. And Ali, could you introduce our wonderful guest for this evening?
I would love to. So you can go ahead to the next slide. All right, so today we're going to be talking about internal medicine, being a hospitalist, and palliative care, and how to deal with the patient's death with today's presenter, Dr. Shaneen Lalani. She is currently an internal medicine and palliative care hospice doctor. She is currently residing in New York, but she works in hospitals across New York and Texas, especially during the coronavirus pandemic. And we are very lucky to have her today. So Dr. Lalani, the floor is all yours.
Hello, nice to meet everyone. Thank you so much for having me. I am so excited to talk about this topic that is so near and dear to my heart. I think talking about patients and dealing with the patient's death and talking about difficult topics like how to break bad news or how to have code status conversations is so important, and it's often not talked about. Being in medical field, no matter what field you go into, whether you are becoming a doctor, a PA, or an NP, or a nurse, whatever field you go into, one of the things all the medical professions will eventually experience is, dealing with a very sick, chronically ill patient. And one of the things all people in the medical field deal with is a patient's death. And I feel like it's a very hush-hush topic and not talked about enough, but it's something everyone should be talking about openly, especially during this pandemic. The one thing we have learned is that people are dying at an exponential rate, and hospitals are packed and full, and important conversations are not being held in a timely manner. So it's really important to talk about these things openly. So the way the session is going to work is that we are going to do a case presentation. I'm going to talk about a case, which is a bread and butter palliative care case. I'm going to talk about what palliative care is, what hospice is, and we'll run through this case. And I'll refer to this case every time I talk about any topic. And this case is going to be about a patient who is one of my patients. So it's based on real life, and we'll refer back to it. And if you have any questions, we'll go ahead and ask that throughout the session. So a little bit about me. I am an internal medicine hospitalist. So I often get asked what a hospitalist is. So when someone is admitted into the hospitalist is a field of medicine that takes care of the patient when they're admitted inside the hospital. So what usually ends up happening is that patients get sick. Let's say if they have chest pain, they go to the emergency room, then the emergency medicine physician sees the patient. And then we decide, does this patient need to be admitted or not, to make sure if they're not having a heart attack or if they need any procedures. So when they're admitted into the hospital, a hospitalist is someone that admits the patient and takes care of them from start to finish. So the way our hours usually work is that we work 12-hour shifts. So I just finished my 12-hour shift today. So usually it is 7 a.m. to 7 p.m. Our schedules are usually 7 on and 7 off. So we work 7 days straight for 12 hours a day, and then we have 7 days off.
It's been a little difficult. I have been working about 12, 13 hours a day, almost every single day, with 24 hours or 2 days off in between. So that's been a little difficult. We've all been very tired, but that's just during the pandemic for the past 2 years. So I feel like now I'm chronically fatigued working so many hours a day. And then what I usually do in my practice is that I do 1 week of hospitalist and I do 1 week of palliative care consults. So palliative care consults are where they consult me for, important goals of care conversations and pain management and seeing patients for chronic illness. And I'll talk about all that when we run through the case. So that's what I do. I'm an internal medicine hospitalist and a palliative care doctor. I grew up in Dallas, Texas. I went to UT Austin for undergrad. And then when I moved to New York City for medical school, and I've stayed here since. I've been living here for 12 years. I went to Toro College of Osteopathic Medicine for my medical school. I did my residency in internal medicine at New York City Health and Hospitals. And then I did my fellowship in palliative care and hospice, which is a 1-year fellowship on top of 3 years of internal medicine residency at NYU School of Medicine. So that's 3 years of internal medicine and then 1 year of palliative care and hospice fellowship. So 4 years of training.
Shanine, your fellowship was in what?
Palliative care and hospice.
I'm sorry. Thank you. I missed it.
And so after that, I have been working as a locum doctor. So what a locum physician is that, how there's travel nursing, there's also travel doctors. So anytime there's a shortage of doctors all around the US, I am hired to go to these hospitals by different companies and fill in for the shortage. So during the pandemic, I was working in New York City, and New York City itself has so many hospitals that I end up just being at a lot of hospitals here. So not only do I work at NYU, I also work at Mount Sinai, I work at New York Presbyterian, and currently I'm at New York City Health and Hospital at this hospital in the Bronx. So it kind of allows me to go to different facilities and kind of, experience different patient population, whether it is a private sector of medicine or public sector. And so during the pandemic, I was also hired to work at pop-up hospitals, which are basically these hospitals that are erected in New York City to deal with the increased caseloads hospitals were seeing. So beginning of the pandemic, we were seeing so many patients that, we were housing these patients in the hallways, in the cafeterias, in garages. And then basically New York City hospital system decided that we need these facilities to house more patients. So in Central Park, we had tents set up to house these patients. All these tents were set up in different areas of all over New York City. And I was in one of those tents for about 6 months to deal with the increased load of patients. Because, when a pandemic hits a place like New York City, it just with millions and millions of people living here in such close proximity, the virus was spreading rampant at a very fast rate, and hospitals were just not equipped to handle it. So because I worked at a pop-up hospital here for 6 months, I was then hired by FEMA to help with a pop-up hospital in El Paso, Texas. So that's where I was last December, working at a convention center in El Paso, Texas. And I was there for about 2-3 months, helping them set up these makeshift hospitals. And it was a very interesting experience because you work with these military doctors that are, in all these countries on the field, and they're working side by side by you at these convention centers that are now hospitals. So it was definitely it's been a very interesting experience. And then for the past year, I've been back in New York City working at COVID units that have been started to deal with the increased COVID cases, part of New York City Health and Hospital Systems, which is a public hospital system. So that's what I've been doing in the pandemic. I currently live in Williamsburg, Brooklyn, which is a section of Brooklyn. And I also do some media contribution when things were, going rampant in New York City. A lot of doctors were getting out there and spreading the word, especially in the news or radio, talking about, what the public can do to protect themselves and protect their loved ones and precautions to take. So then it just kind of started becoming a passion of mine to do it more and more. So now I'm going to move on to the case presentation. Before I start, I just want to say, this can be a very sensitive topic for a lot of people. And I understand if you feel like you need a break. This is a very sensitive case, but I think it's very important for us as future providers and current providers to talk about these difficult to talk about cases, because it's something all of us will eventually experience. So this case is a 45-year-old female, and this was one of my patients, with stage 4 metastatic breast cancer. She is admitted to the hospital with severe pain in her hip and lower extremities and upper extremities due to bone metastasis. So her cancer has spread everywhere and is causing her to have intense pain. Her disease has progressed and she is more tired with decreased ambulation and decreased appetite. She follows with the oncologist, which is the cancer doctor, regularly, and she is no longer a candidate for chemotherapy. So just because you follow with an oncologist does not mean that, they will automatically always give you chemotherapy. There's certain criteria patients have to meet in order to get chemotherapy. They have to have, certain functional status, certain labs, certain lifestyles. So she was becoming too sick to handle any more chemotherapy. She was rapidly declining. You are consulted as a palliative care doctor to discuss goals of care. A little bit of social background about her. She is married with 3 children. She works as a biology teacher in high school, and she is very involved in her church and community. So what is palliative care? So palliative care is a field in medicine that focuses on anyone with a chronic serious illness. So what is a chronic serious illness? A chronic serious illness means cancer. It means end-stage renal disease, someone that is on dialysis. One thing we know is that if someone has renal disease and renal failure and they're on dialysis, we already know their life expectancy is not going to be past, a couple of years or even 6 years. So these are what we call chronic patients, chronically ill patients, which are the type of patients that have been affected by COVID the most. It's what you usually read, what you see in the news is that if you have a chronic illness, COVID is bad for you because your body is already taken a hit dealing with this illness. So it could also be heart failure, end-stage heart failure. Heart failure usually has 4 stages. So anyone that is starting to reach stage 3 and 4, dementia, patients that start having dementia that's rapidly declining, what ends up happening is that they're eating less, they're sleeping less, they're, talking less, and eventually dementia can be so crippling that you're reaching end of life. So end stage dementia. So any chronic illness, palliative care doctors are consulted. And what our job is to provide symptom relief. So during fellowship, majority of our training is in pain and symptom management. So we are really good at pain management. We're trained in how to properly prescribe opioids, how to convert between opioids, what opioids to use, what opioids not to use, what medications we can use to promote, to, help with any nausea, chemotherapy-related nausea this patient might be having, or cancer-related nausea, medications to give to increase appetite, to increase alertness, all based on patients' goals and wishes. So that is a really big part of what we do as palliative care doctors. But then our job also is having difficult conversations, whether it is telling patients they are no longer a candidate for chemotherapy or breaking bad news to them about how their cancer has progressed, providing support to families, establishing rapport with families, especially when we're involved very early on. And we work in a multidisciplinary team approach. So it's never just me. It is me, there's a nurse practitioner usually, or a PA, there's other nurses, there's social workers, there's grief counselors, there are therapists, there are all these people that are involved in my team, and we, manage the patient as a whole. And then part of our job is also to address their emotional and spiritual needs. And it's appropriate at any age and any stage of the illness. So you could be a pediatric patient, you could be a child that has been diagnosed with cancer and needs help with symptom management, or the parents need support in dealing with this life-threatening illness their child has been diagnosed with. So at any stage and any age. So any of these diseases we see. Hospice, on the other hand, is for anyone that has a life expectancy of 6 months or less. So in order for someone to qualify for hospice, they have to have 6 months or less to live. Now, people often think of hospice as a place a patient goes to, but it's actually a service that is provided. So the hospice service itself, the way it works is that there are these hospice companies that provide services to patients anywhere. So hospice can be inpatient when they're admitted into the hospital, which is called inpatient hospice. It could be a hospice facility. There are some hospice facilities where the entire building is just a hospice, and those are also called hospice facilities. Mostly it is home hospice, which is where the patient decides to die comfortably at home. So these services are provided to them at home. It could be also be provided at a nursing home. We have a lot of elderly patients that don't have homes, or there's no one that can take care of them at home. So they go to nursing homes, and hospice services can be provided at home as well. So what ends up happening is that these hospice companies send hospice physicians. I've done hospice before, so doctors like me that are trained in palliative care and hospice. They have hospice social workers, hospice chaplains, hospice grief counselors, and all of us providers go visit patients at their homes or whatever location they choose to get these hospice services. So majority of the time, it is at patient's home, which is called home hospice. That's when, as I said, patients have decided that they want to die comfortably at home, surrounded by their family and friends. One of the discussions we often have in the medical field is that the way patients are dying now is changing compared to the beginning of time. So in the beginning of time, patients would, in the 1800s and 1700s, beginning of time, patients would be dying at home. The doctors would visit patients at home, and the patients would be dying comfortably in their bed. But now patients are dying, majority of patients die in hospitals. So not that concept of dying at home surrounded by your family and friends, even if you know you're dying, no longer exists that openly. So most patients now die in the hospital, in the ICU or medical floors. They are not surrounded by family. They're usually attached to a ventilator, or any of these invasive measures based on what they choose, or not choose. And that type of dying process is very new. And that's something that happens with all these medical advances, where, the conversations on where we have chosen to die comfortably are being held less and less. So, when patient chooses to die at home, let's say if someone has metastatic cancer and they choose that, okay, I have 3 months to live and I want to be at home and surrounded by my family and friends, then that's what physicians, like hospice physicians like us, focus on. So what ends up happening is, like, this patient says, I have 3 months to live and this is what I want to do. I have 6 months to live and this is what I want to do. So then I tailor their medication regimen to fit their goals and wishes. So for example, let's say someone says, I have 8 months to live and I want to be able to travel to this location, and that's where my family is from, and I want to make sure that I'm able to comfortably get there. So then I look at their medication regimen, I see what medications we can provide to optimize them, because most of us hospice physicians are also internists or family medicine physicians, and we're very comfortable with, treating just the general medicine aspect of things. And then we titrate their medications in a way where they're able to stay up more. So for example, if patient's like, I'm so sleepy, I'm unable to talk to my friends and family, then I would, prescribe them something like a low dose Ritalin or something like that to make them more awake during the day, so they're able to have and enjoy time with their family and friends. So a lot of the medication changes are based on, what the patients tell me they want to do and how they want to live the last few moments that they have.
So but before you continue,
Yeah.
we got like a question that's very popular in the chat, and it's kind of a hot button issue for a lot of physicians. The idea of euthanasia. We were just wondering, as someone that works so much in hospice care, what are your thoughts on the procedure?
Okay, so I've worked at a hospice physician in Portland, Oregon. So Portland, Oregon has Death with Dignity program.
Right.
So what death of dignity is that when patient has documented less than 6 months to live. So what happens is that two hospice physicians, or two, usually it is, a hospitalist and a hospice physician, or a primary care physician that has been following the patient very closely. Two physicians agree that the patient's life expectancy is 6 months or less. We make sure that patients don't have any psychiatric illness. For example, we have to make sure that they're not depressed and making this decision to die based on an acute change in their mental status. And then once we agree on that, and there's documentation to prove that they do have, their life expectancy is only a few months, and they have full knowledge of what they are about to do, then the hospice physicians prescribe a combination of medication where the patient takes it, and then they pass away.
Right.
So the way it usually works is that there are all these services that are available in these companies that do death with dignity. So the physician writes the prescription for the medication itself, and then these companies that have trained nurses and people from the community go over to the patient's home and give them the medication, and usually the patient is surrounded by family and friends, and then that's how they die. So I've seen few of them being in Portland, Oregon, where it is common. But so I have a few thoughts on that. Okay. So first is that the prescription that we provide for death with dignity is a combination of medications that stops the heart and also provides pain relief, like morphine. So a lot of patients that are prescribed these medications to take, majority of them don't end up taking the medication. For a lot of them, it's about having control that, if things get bad, I want to be in charge of being able to go on my terms and wishes. I don't want to be a burden. I don't want to be in pain. Right. I don't want to have control. I don't want to lose control of my own body. So majority of those patients that are prescribed death with dignity medications don't end up taking it. Palliative care services have also gotten a lot better, especially home hospice services, where the physicians are now going into patients' homes. So let's say if a patient is in a lot of pain, we have very high dose opioids that we are prescribing to manage these pain symptoms. So a lot of patients, because the pain management has increased, prefer taking that route than actually going through with death with dignity. It's very rare that patients actually go through it. The ones that do go through it, one of the things we've seen is that, they're usually from higher socioeconomic statuses. They're usually very, very educated. Right. There's certain trends you start seeing in patients that actually do go through it. And in the end, it's a personal decision. I believe that everyone should have control in what, we don't control how we come in. I think we should have a say in how we go.
Yeah,
But do I believe that, everyone should be prescribed these medications? I'm honestly not sure, because I think there's a lot of factors that go into play. And you sometimes don't know a patient's mental state. They might say, this is something I want to do now, and then a week later they decide not to, and their symptoms are better controlled. So my answer is always that it's very important to properly palliate the patient, which means that it's very important to make sure that we're giving them the best pain management and best symptom management available, so they're able to then make the decision on their own. So it's a very it's not black and white.
Right, it's a very like gray issue. Each case is dependent on the person's medical history, what they want, how they want to go, and that sort of thing.
Right.
All right,
Janine, is there a movement across the nation to try to increase the number of states who allow this procedure?
There definitely is, but I don't think all states are open to it, because there's a lot of unknowns. Some countries are more open about it than other countries, but I'm not exactly sure why certain states are not open to it and certain are. I would say that we do live in a very death-denying culture. People don't want to talk about these things openly. It's a very difficult topic, and when something's very difficult, people just rather not talk about it or even think about it. But I think because of way medicine is going, because people are getting more educated and involved in their own care, there is definitely a movement in, more and more states adopting it, or at least learning about what it is, because I think everyone has a preconceived notion that it's very easy to do and very easy to get, and that's not true. There are physicians that have to sign off on it. You have to be evaluated by psychiatrists to make sure you're not depressed. There's certain medications that are prescribed. Majority of the time, these patients don't even end up taking the medications. But the big thing is that having control is what most patients want. And there's a reason majority don't go through it. I think a lot of them just want to know that if something happens, I have control.
Yeah, that's so true. We planned so much for the coming of life into the world. The baby is coming. We redo the bedroom. We paint it pink. We have balloons and flowers and all that, and we celebrate the arrival of the newborn into the world. But we really don't plan well, by and large, for the end of life. We plan for the beginning, but not for the end. And you would think that after a long life, especially a long life, that celebrating the end of life would be something that would be natural, but it's mostly not natural, I think, Janine.
Yeah. Yeah, because
go ahead, please.
I mean, because it's difficult. No one wants to think about their death. And I think as human beings, we're created in a way, even psychologically and mentally, to not think about it. But, you don't have to think about it, but it's important to talk about it. It's important to talk about, what type of death is a good death, what type of death is something you're okay with or not okay with, because as physicians and as medical providers, it's our job to kind of show the reality of what really happens, because everyone watches TV and thinks they have this weird concept of CPR, that when your heart stops, all this medical team's going to come around you. They're going to do CPR. They're going to shock you. And then you're going to come back to life and, eat a burrito or something. And that's just not reality. Your heart just stopped and you medically died. You're not going to come back to life and, be able talking and having these detailed conversations. And that's what TV does. It shows a very false perception of reality. And most people get their perception of what happens in the medical field watching these TV shows.
It strikes me that in a way, modern medicine kind of almost condemns many people toward a suicide end of their lives. They're in terrible pain. They're not allowed a euthanasia or physician-assisted suicide, or whatever you want to call it. And so instead, they end up in a, gasping out in a miserable situation. And you would almost think that it would be very natural that facilitating the ends of the lives of our patients would be part of the oath of medicine. It's something to think about.
Right. And I think the hardest part is that these patients don't have a say in it. And by the time we're having these conversations, it's too late. If someone has metastatic cancer and you know their life expectancy is 6 months or less, and you know that because of the research we have in patients that have similar type of illness, and the fact that you've never even had the conversation, no medical provider has conversations with these patients about, okay, so this is what's going to happen. Eventually, you know, you're going to die, and you need to let us know that if your heart stops completely on its own, despite all the medical care we provide, do you want to go naturally, or would you want CPR? And explaining to them what CPR is, where we restart your heart by thumping on your chest and, you know, shocking you and putting you on a breathing machine that breathes for you. And it's a possibility you might not be removed from this. And, you know, you have an underlying medical issue like cancer that cannot be fixed. So even if we do CPR, what's the end goal, you know? And these type of difficult conversations are never held. So, you know, our patients that have, you know, initial stages of dementia and they're 83 or 90 years old, and asking them like, okay, this is going to get worse and you're not going to eat, you know, would you want CPR? Do you want to go naturally? So if these conversations are not even being held early on with these patients where they're able to participate, you know, then you're just kind of leaving it to family members that have a lot of times very low health literacy, and asking them to make these very difficult decisions. And I think it definitely differs from country to country, because in the US, we give all these decisions to the patients. We're like, okay, so this is the menu. This is what we have. Do you want this? Do you not want this? Do you want this and this? As opposed to some other countries where it's a very maternalistic or paternalistic approach, where the physician kind of makes the decisions from the family, where the decision process is taken away from the family, and they're just kind of told like, okay, we're not going to be doing CPR because it's medically futile. It's not going to benefit the patient. So in the US, we don't have that approach. We have the approach where like, okay, it's medically futile, but do you want it? You know, and I don't know, I'm sure you have similar experiences as well.
Oh yeah, well, not to mention, Shanine, the medical legal environment in America,
Right,
where you know, if the family thought you were being too boisterous or hoity-toity, or
right,
making a cavalier recommendation based upon your own vanity as a doctor,
yeah,
that you could stand to be sued. And
correct.
and so the cafeteria plan that you mentioned has emerged that says, you know, here are all the choices you can make to someone who is riddled with cancer, in horrible pain, with multiple fractures, and who is absolutely miserable and has gotten into a situation of inability to make wise decisions for themselves.
Right, I completely agree.
Please go on. This is just
Right.
this is this is
And that's a very interesting topic. And
yes, Shani, this is magnificent. Please go on.
so I work in an interdisciplinary team approach. Like I said, it's never just me on my palliative care team. So the way it works is that I see these patients and I discuss it with my team. So on my team, I have me, the physician, the doctor that does all the medical decision making, given the medications to give, the opioids to prescribe, the medications to give to manage symptoms, whether it is chemotherapy related nausea, vomiting, or you know, constipation, or all these type of weird symptoms that tend to happen end of life. And we're trained in using medications that we don't usually use. So for example, let's say if someone comes in with severe nausea and vomiting, and you know, most physicians give medications like Zofran, which is this medication that targets the 5-HT receptors to control the nausea. But as a palliative care doctor, I actually have a list of medications I use. You know, let's say if someone comes in with nausea related to increased intracranial pressure in their brain, so it's brain metastasis and there's a lot of swelling in the brain, then I usually give steroids for nausea. Let's say if it is nausea related to low gut motility, then I give Reglan, which is metoclopramide, which is another medication we use for nausea. Let's say if it's related to chemotherapy induced, then I might give something like neurokinin or neurokinin inhibitors, or Haldol even, which targets the certain dopamine receptors that we know targets nausea, vomiting. So in the end, it's just a horde of medications that we use, and it's never just the basic ones used by most physicians. So that's where majority of our training goes into, to learning different types of medications to manage symptoms. So I also have a nurse or a nurse practitioner and a PA on my team, a social worker who is a very vital part of the team, a palliative care trained chaplain, because during end of life, it's very important to address the spiritual aspect of patient care, and then therapists and grief counselors. And we'll kind of discuss each of their roles. So the approach to palliative care and hospice is what I call a mind, body, and soul approach. So we look at the patient as a whole. We're not just looking at, their pain or their social aspect of things. We're looking at everything that makes a patient a whole. So not just the pain and symptom management, but also the psychosocial aspect of things and their religion and other aspects that make the person their personhood. It gives the person their personhood. So back to the case, we have the 45-year-old female with stage 4 metastatic cancer admitted to the hospital with severe pain in her upper and lower extremities due to bone metastasis. Her disease has progressed and she's more tired with decreased ambulation and appetite. Her oncologist has said she's no longer a candidate for chemotherapy. You're called in to manage any pain symptoms and also discuss goals of care. She is married with 3 children. She works as a biology teacher. She's very involved in the church and community. So pain management. So when I see these patients for pain management, I'm taking a very thorough, detailed pain history. So the mnemonic I usually use is PQRST. So I look at pain. Where is the pain located? What's the quality of pain? Because in my head, I'm trying to figure out what type of pain is it, because different types of pain are treated with different types of pain medications. So is there anything that makes it worse? Is there anything that makes it better? Does it radiate anywhere? Where is the pain located? How many areas of the body are in pain? Did you take anything at home, like, for example, Tylenol or anything that made the pain better? Did anything make the pain worse? And getting a detailed pain history kind of gives me an idea of what type of pain they are having. So there's different types of pain. There's somatic pain, which is basically pain that occurs when there's tissue injury. For example, there's pain in the joint and the skeletal muscle and the connective tissue. And this type of pain is usually activated by force or temperature. The pain is described as cramping and gnawing. So in this case, where there's a bone metastasis, it is a somatic type of pain. Nociceptive pain is just basically a general medical term used to describe potential damage to the nerves of the body. So for example, from a sports injury or dental procedures or arthritis. Neuropathic pain is what we describe nerve pain when there's injury to the nerve. This pain is usually described as burning and tingling. We see neuropathic type of pain when we see diabetic patients that come in with nerve pain in their extremities, and they'll usually say like, oh, doc, like I have this like burning and tingling pain. So it's important for me to ask, is it burning and tingling? Is it, cramping and gnawing? Where is it located? So if it's burning and tingling type of neuropathic pain, I would be giving her different types of medications. We usually give medications like gabapentin or Neurontin, basically medications that target the nerve type of pain. But in this patient, it's bone pain. So what we call it would be a somatic nociceptive type of bone pain. And the best medications to treat these type of pains when Tylenol doesn't work is opioids. Where majority of our training is in how to prescribe opioids safely. I think opioids get a very bad name, but there's a place for them. And the place for them is, end of life palliative care and hospice patients that have cancer pain and pain that's just making their life miserable. So the type of opioids I would use depends on the type of pain this patient has, but also, I would be looking at their lab work. So few opioids that we usually give are morphine, oxycodone, or Dilaudid. When to use when depends on their kidney function. If someone has kidney injury or bad kidney function, then I usually opt for something like Dilaudid. If they have liver failure, then, there's other medications like fentanyl or other pain medications that we use. And the choice of opioids then depends on the kidney and liver function. One of the sayings that my, NYU program director has is that the hand that prescribes the opioids also prescribes the stool softeners, because one of the most common side effects of opioids are constipation in patients. So, every time I prescribe any opioid, I'm making sure I'm giving them stool softeners and advising them that, it can lead to constipation. It could lead to some nausea, it could lead to some vomiting, it could lead to some drowsiness. And sometimes the body just requires a few days to adjust to these opioids, especially if they are what we call opioid naive, as in they've never used opioids before. And then and there's also further type of pain management we do. So let's say if it's a single lesion, that means the cancer has metastasized to the bone and causing them a lot of pain in the bone. Then if it's one or two lesions, I often refer them to radiation oncologists that do radiation to that specific area of the bone. And that often works wonderfully, because then I don't have to give them systemic medications like opioids. You can just, from the outside radiate the one area. It's obviously hard to do if there's multiple bone lesions. You can't radiate the entire body, but it's really good for one or two bone lesions.
Hey, Shanine, can you go back to that previous slide before this one that showed? Yeah, right there. For the go back one more. Right there. For the students, there are three parts of pain. She's shown them here, but look at that drawing. There's pain out in the periphery that's actually produced locally in the tissues. And then those nerves come to the spinal cord where they synapse. And that is a central type of where pain crosses going upward to the brain. And then there is the perception of brain, how you actually perceive it up in the brain. And therefore, different drugs have different places where they work for pain, such as ibuprofen and Tylenol work out in the periphery. Morphine works in the periphery, but also in the synapses and the spinal cord. And then such drugs as ketamine, for example, work on dulling the perception in the brain. So you as future clinicians will be having to think about these things, especially, and Shanine, I bet you would agree, as new treatments are able to address these three different areas with the passing of time.
Yeah, that's completely true. The idea of pain management is that there's receptors in your brain, like the opioid receptors and the mu receptors, and you're basically blocking the channels that tell our brain that you're feeling pain. So, the opioids target the mu receptor in the brain, blocking this, the synapses and blocking the transmission of pain going to these receptors. So it's kind of cool when you really think about how pain management works. It's kind of telling your brain, cutting off the signal to feeling the pain. The pain is still there, but your brain is just now not feeling it, which in turn means you're not feeling it. So the psychosocial, one of the things you'll notice if you ever come across a palliative care consult note, when I do my palliative care consult notes, I have the HPI, which is, where I give a little bit background of what the patient is doing. And I include a very detailed social history, because the social history is so important for me to get to know my patients and who they are as a person. And after taking a detailed social history, I get a better idea of the type of decisions they need to be making or I need to help them make. So, for example, this patient has 3 children. She's currently married. That's a very big part of her life. If she has 3 children, I need to make sure that my social worker is involved to help, discuss these sensitive topics with the children. And that is added stress to the patient when they have children involved and, thinking about like, how am I going to tell my children now that, I'm dying and I'm not going to get chemotherapy? How is this going to affect my marriage? And getting the appropriate help. So that's why we always look at patient as a whole. And, the other questions I often ask is like, well, how do you live your life? Like, how independent are you? Sometimes these patients come in that have a very poor quality of life to begin with. They're 90, they have severe dementia. I often ask the family, how are they at home? And they're like, yeah, she hasn't eaten anything for like a year now. She's barely eating. She mostly lays in bed. She used to be very active. She used to be very involved in her community. She used to go to church all the time, but for the past year, she's just had a very poor quality of life. And this is not the life she would want to live. And knowing this social background is so important for me, because then when that conversation is being held regarding code status or, do you want CPR? Do you not want CPR? I can kind of get an insight on patient that she used to be independent, and being independent is very important to her. So if she does get CPR and she's going to be on the ventilator for the rest of her life, that's not the life she would want. So then I can advise the family that, these are my recommendations based on what you're telling me and how independent she was, and now she's not, and her quality of life is just so bad. CPR is not going to make her quality of life better. It's actually going to make it worse because now she's going to be more bedbound than usual. So getting a detailed social history and honestly just getting to know your patient as a human is so important, because that's what helps build that social connection. And that's how patients trust you and the decisions you help them make, because they trust that you've gotten to know them as a person and you're not just looking at numbers and charts, you know? And so that's why a social worker is a very big part of my team. Spiritual aspect of care, end of life for most patients, even if they're religious or not religious, spirituality is very important. One of the questions I think as humans we all ask is, what happens next? Where do we go? And you know, different religions have different customs that they do end of life, and it's so important to involve our palliative care chaplain in these patients' lives, because a lot of families, for example, if I have Buddhist patients, they have certain rituals that they do end of life, or Hindus or Muslims or Christians, and there's different types of Christians that do different things and believe different things. For example, our Jewish patients have different ways of decision making when it comes to end of life care, and they want their you know, rabbis involved and priests involved, and those type of conversations are very complex. But it's so important not to deny that part of care. And it's often something not discussed openly while we're taking care of these patients. But when end of life is in picture, then, you know, these type of subjects become very important. And denying someone their religion or things they do that brings them solace for families or even for the patient themselves is denying their personhood.
You know,
So next, yes.
Shanine, when my mother made 93 and ended up with a surgical issue, acute emergency, and ultimately decided that she was ready to go. She leaned forward and said, through her BiPAP in the ICU, and said, "Let me go." And so I had the dubious responsibility with my brother of signing the DNR on my mother. My mother was absolutely prepared as a very strong Christian all of her life that when she closed her eyes, she would cross the river and be with my father, who had died 10 years prior to that. And, you know, I think it's interesting as doctors if we don't necessarily share the beliefs of our patients, but on the other hand, we want to be supportive of them in their belief structure. You know, we've got to let the patients believe what they believe, you know?
Right. I completely agree. I think it's our job not to impose our beliefs, but it's so important to be supportive of whatever beliefs they have, because that's what they've grown up with and that's what they believe. And there's no one single right belief. Everyone has the right to believe whatever they want and get the answers and go on their own journey. So it's so important to be supportive of everyone's spiritual background and respectful of it. You know, a lot of times patients would say, like, can you join our prayer circle, or, you know, help us pray with our mother or pray with our father. And as physicians, you're going to be asked that. And it's okay to say, no, I'll be here, but, you know, it's okay to join as well and celebrate you know, the way they celebrate life. So it's a personal decision. It's something you're probably going to be asked one time or the other, but in the end, you know, it's important to just be supportive. You know, I always make sure that our chaplain is involved and right people from the community are involved, because it really helps with the grieving process as well. So, you know, providing good spiritual care, and this is not religion specific, in the end helps patients, families, and patients kind of accept things end of life and the circle of life, and also helps families. You know, certain rituals are held after the patient dies, and hospice physicians are often asked if they can be involved or you know, join these certain practices that they might patients, families have, and most of the times if we're able to, we always join. Because it's important for them to grieve in a healthy manner. And if that's what helps, then that's what helps.
Shanine, do you, this is kind of a semi-personal professional question. Do you feel, and I'll certainly tell you what I think, do you feel that being present at the end of so many patients has affected you both professionally and personally, maybe affected your own belief structures, or, but just any comment you wouldn't want to make?
Yeah, of course. I often say that practicing as a palliative care and hospice physician has changed me as a human. Being exposed to basically being reminded of your own mortality kind of changes the way you live life. I think since I've been practicing as a physician, palliative care physician, and just knowing that at any moment, we can die, and that can happen at any time. I often tend to not, get upset with little things, and always tend to see the bigger picture. Not all the time, though. My partner would disagree, but but majority of the time, I don't fuss the little things. And the way I want to live my life is that, okay, my life is truly short. Anything can happen at any time. So it's so important to just focus on things that make me happy and live the life I want, because tomorrow is not promised. And being involved in patients' lives at such a critical time, especially end of life, also makes you see so many things, and question a lot of things. And I feel like I've become more and more philosophical, in a sense where I just, you sometimes see things and you question, why is this happening the way it's happening? How is this fair? This person was so nice. Why is that they're going through this? And it's just like these constant questions and answers I ask. But I feel very honored to do what I do, and it kind of shows you just, I feel like I see a lot of humanity in things. I see the way families treat their loved ones, and how physicians treat these patients, and how nurses treat these patients. And I definitely see the human aspect of medicine that I feel like, because of this documentation and charting, we are kind of moving away from.
I've come to understand in emergency medicine that I sort of have two jobs: to save life where I can, and to make people comfortable when I cannot.
Right.
And, and I've been in medicine almost 50 years altogether now, and I have to say that it's been a long time coming, but it's never been more important. I think now, to help people, understand their situations as best you can, which is often a challenge, especially when there's a significant language barrier and so forth.
Mm-hmm.
Anyway, thank you. That's marvelous. Please go on.
So the next topic I want to talk about is breaking bad news. So one of my jobs as a palliative care doctor is to break bad news. So for example, in this patient, it would be telling her that she is no longer a candidate for chemotherapy, and she might have 6 months or less to live. So there's this protocol that I was taught in fellowship that kind of serves as like a guidance on how to do these things. The reality is, the more you practice and having these type of conversations, the better you get at it. So it's not something you just wake up with that comes naturally. I was in training for it, and I have so many of these conversations, and each conversation, each patient is different and has to be, all the conversations have to be tailored to that patient and that family. But there's a SPIKES protocol. So S stands for setting up the interview. So let's see, for this patient, for example, I'm going to go into her room, and I'm going to tell her that, hey, there's something I want to discuss with you. I make sure that it is a private setting. I make sure that, the TV is turned off. You don't want like something raunchy playing in the background. You want to make sure it's a very calm environment. I want to make sure, if there's family around, everyone is sitting, because I'm about to give them life-changing news. Everyone is calm and they're able to understand what I'm saying. So S is for setting, P is for perception. So then what I do is I ask them, what is your understanding of your illness? What is your understanding of what's going on? And what have the doctors told you so far? It is shocking to see the amount of times patients have not been properly told what is going on, and their understanding of what is going on is completely different than what's actually going on. So it's always good to kind of get a background on where they are and what they know. And so, for example, in this case, they would say like, oh, the doctor told me that I'm getting chemotherapy, and this is where my cancer is. And then I ask for invitation. I ask them, is it okay if I discuss something with you regarding your cancer treatment? And most of the times patients will say yes. I want to hear more about my disease, if it's working or not working, what's going on. Sometimes, based on cultural backgrounds, patient might say, you know what, I don't want to know more. I want you to discuss it with my oldest son. We often, living in New York City, you are exposed to so many different cultures, people from all over the world, and you realize family dynamics play such an important role. So a lot of times, sometimes what I see with my Chinese patients is that, they would often say, they often sometimes say that, um, I don't want to be involved in decision making. I want you to, especially older Chinese patients, would say that I want you to talk to my eldest son and discuss everything with him, and I want him to be the decision maker. And it differs from family to family. So it's really important to ask the patient. It's your job to give the patient information, but the patient can also refuse to receive information. And then K is for knowledge. And then I tell them, so you have been getting chemotherapy, but because of the progression of your disease and your functional status and your lab work, you are no longer a candidate for chemotherapy. And usually the oncologist is by my side giving this information as well. And then E is for emotions, which I personally think is the most important part. This is where, you just gave them life-changing news. And as a physician, you want to make sure that you are there to emotionally support them. That no matter what happens, you're still going to be here for them. You're still going to provide care for them no matter what. And you're here to, support them. At this point, the patient is usually crying. The family members are crying because this is just sensitive news, and it's your job to just be there for them. And then S is for summarize and strategize. So then in the end, I always say, I just want to summarize what we just discussed, and these are steps going forward. So this is kind of the method I use to break bad news. It's never goes as planned, but I try to follow this methodology in a fashion every time possible. So
do you find that sometimes the case is more precipitous, the patient is proceeding pretty quickly toward the end, and you have to kind of put it on fast track?
Yes. Yeah. A lot of times, especially if we're involved very late in the care. One of the things, during COVID, I've received 30 consults a day. And a lot of times they're like, okay, patient's intubated in the ICU and he is actively dying. So you need to tell the patient's family that they're actively dying and you need to ask them these questions. And so, we're kind of involved late, and I just have to get the information out, but there's always a way to communicate professionally, and there's a way to break these news professionally. And in the end, it's important that the families know that as a medical provider, you're always going to be there for them no matter what.
What if they get angry? How do you handle it?
They often get, if someone is telling you that your loved one is dying, or, the medical intervention right now is not working, they will get angry. But in the end, you assess their emotion. One thing I always, tell my team is that they're not angry at you, they're angry around you, they're angry at the situation. And this is a normal human emotion. And you always have to maintain your professionalism and try to explain things the best way possible. You have to kind of always have, practice mindfulness and have a game face no matter what. And that's just something that comes with more and more training.
So how do you handle it when you have just a heart-rending situation, but then you have to walk away and go see another patient because you've got a job to do? How do you process that? Or do you sort of tuck it away for later?
Yeah, that's a really great question. It's actually the most common question I get asked. How do you handle this? How do you handle constantly seeing such sick patients? And to be honest, I don't think this field is for everyone. It requires a certain type of person, I would say, to deal with this type of grief and sadness sometimes at all times. But I say that I have always been blessed with a very strong support system around me, especially my colleagues that are always very supportive. I always talk things through. Things never get easier. It's not like seeing someone die, you're just kind of numb to it, but you learn better ways to process it. You learn holistic ways to process it, kind of understanding that this is part of life. I have a very supportive partner that I come home to, that he's always there for me. We're able to talk through it. I have very supportive family and friends. I maintain a very good healthy work and life balance, which I personally, to me, contributes a lot to the way I handle these things. I'm social and I like to be around my friends and family. And so just having a good work-life balance is truly key, which hasn't existed during the pandemic as much as I would like, but it's something what I aim for.
I remember one time, this is a quick story, that I was in the ER and an ambulance called. They were coming in with a desperately ill woman. And it was end-stage cancer, and came in. It was just, woman was in awful shape, hyperventilating, just about to die. Family got there and they said, "Doc, we just couldn't do it at home. She went home to die, but we just couldn't do it." She didn't want a tube in her throat or anything. And I told them, I said, I could do some things for her, but it's not going to help. They said, well, we just couldn't do it at home. And then the sons, we sort of gathered around her, and the lady was just about at the end. And the son said, "She always loved the song Amazing Grace." And I said, "Well, why don't we sing it to her?" And so, Shanine, we stood around that lady and we sang Amazing Grace. And I swear to God, at the end of the last verse, she died. And I said, "I'll be down the hall if you need me." And I get down to my little room and I cried like a baby. That was so hard.
Yeah, no, these are such hard cases, and there's so many of them. And especially during the pandemic, I would say it's been the hardest thing to see so many patients die without their family members around. When people often ask me what's the hardest thing during the pandemic, I say seeing these patients die and their family can't enter the hospital. We now have FaceTimes and video calls set up in a way at our hospitals where the family members can at least go see the patient. But I know in the beginning of the pandemic, they couldn't even go to the morgue. We were still trying to figure out how contagious these patients are after they die. We didn't have much information. So the families, would be worried sick because our hospitals were packed. We weren't able to call them every hour of the day because we had to take care of these patients, and the family members would then just get the call and be like, "Wow, I didn't even get to see them. I didn't get to talk to them." It was just so crazy. And I think that was the hardest part for me, just seeing
for all the political discussion and all the stuff going on in the news, the people that are talking about it haven't been what you and I have done, where we've stood there and watched these poor people with an endotracheal tube jammed down their throat, with on a ventilator, dying, not alone because we're with them, but not with their families, and not in a prepared, environment that is surrounded by love, other than the professional love that we show them. And that's hard on us, Shani.
Right, definitely. And it was just so difficult. I remember in the beginning, I was using my phone to FaceTime and call, and you're in these rooms and you're just gowned from head to toe in like heavy gear, and you can barely breathe, and you're just there and you're with the patient. And it's just, I feel like just thinking about it sometimes gives me PTSD, because it was just so difficult to see so many patients die. I remember beginning of the pandemic when I was at the hospital, usually a hospitalist census is about 12 to 15 to 17 patients per hospitalist. My census would go up to 30, 40 patients, 50 patients.
Sick patients, yeah.
Sick patients where they're okay 1 minute, the next minute they're in kidney failure. 6 hours later, their creatinine, which is what we use to monitor kidney function, go from 0 to like 8. They're in liver failure. You're like, what's going on? And then next day you come in, they have died, and you just kind of question, what is it that I could have done differently? But there's just so many of them. And then we figured out that it's this virus, and this is how the virus functions and what it does. So, I think that's why it's really difficult when the pandemic has been made into a political issue, because if only they could be on the front lines and see what we saw, it wouldn't be, I think people would realize that this virus affects us as a species as a whole. It's not just certain group of people, it's all of us. So, yeah.
What a great discussion, Shanine. Please, I'm sorry I'm interrupting so much. Okay. I just love what you're saying. Please go on.
Thank you. So next is like goals of care conversations. I don't time? I feel like I've been talking for like an hour.
Oh, you can talk as long as you want. We just
Yeah,
don't. I know
I'm
you've been
almost
working
done.
on.
It's almost
I know
done.
you've had a 12-hour shift today. We don't want to wear you out. So.
Oh, it's okay. It's okay. So goals of care. So now basically what the next conversation it would progress into is me asking this patient, okay, so you're no longer a candidate for chemotherapy. What are your goals and wishes? Would you want CPR or would you want to go naturally? Let's say if you were 20, if it was a 21-year-old and if they had a fixable issue, then we would do CPR. But since you have cancer that has spread everywhere, the chances of CPR working are very low. Would you even want to go through it, or would you want a trial? Some families say, you know what, try it. Would you want a trial of intubation? Intubation is when we, intubate you and put you on a ventilator. It's important to always distinguish conversations between CPR and intubation, because you could have asthma and say that, okay, you do want to be intubated and be on the breathing machine, because usually some patients with asthma improve with a few days trial of intubation. So these are very complex conversations, and they're never just black and white, and they're very specific to each patient. So for this patient, after a detailed goals of care conversation, she decided to be DNR, DNI, and die naturally at home.
All right, it is time for our first Q&A. Before we begin, I just want to say a quick thank you to everyone that's watching in the chat. We've been asked a lot of questions today. It makes sense because it is a very interesting and quite emotional topic. So we got so many questions. I'll try to ask as many as I can.
Yeah.
So we'll start off first about you being a locum doctor. A lot of people don't know exactly how to become a locum physician. So what path did it take for you to become a locum physician, and how did you handle different end-of-life care protocols and policies when you go from different states?
Yeah. So basically, once you graduate residency and you're ready to practice on your own, a lot of people sign on with in a hospital setting or a private clinic setting or an outpatient setting. Instead of signing on as a hospitalist in a private hospital or public hospital setting, you can sign on with these companies that there's hundreds of companies out there, locum companies out there. It's kind of like travel nursing, like how travel nurses go to different hospitals. It's the same concept. So these locum companies hire you and they tell you like, okay, these are the hospitals we have wherever you're licensed. I'm licensed in New York, so they present me New York hospitals, and I have a few other licenses in different states. So they tell me, okay, these are the hospitals that need help on these days. A lot of times, a physician has quit or an emergency happened or someone went on maternity leave and they're like, we need coverage for 3 to 4 months.
Right.
We need specific dates covered, or they're very short staffed and they need to, usually it's in middle of nowhere or rural America that needs doctor shortages. One of the things I realized doing locums is that, all right, when I graduated residency, I wanted to do international medicine and go to places where there's a shortage of doctors. And then I realized my own country has such a severe shortage of doctors, especially in rural areas. So I did a lot of rural medicine where I would go to, middle of nowhere in Missouri and other states where there weren't many doctors. And I would go there. So basically these companies would fly me there. So I live in New York. This is my hub. So these companies fly me there. They pay for my flight. They put me in a hotel, and then I'm there for like 5 days straight usually, or 6 days or 7 days straight. I go to these hospitals, and most of them have, in the end of life protocols are similar, but most of the times I'm doing a hospitalist work, which is where, patients are admitted into the hospital and treating them in the hospital, since I do internal medicine hospitalist and palliative care. And then so I work there for 7 days and the company flies me back. And then I usually, don't work for like a week or a week and a half, or I do palliative care work, or I work at one of the hospitals I'm credentialed at in New York City. So it's a very detailed discussion, but that's basically what I do.
Right. So another question that we've gotten a lot, I think this is probably one of our most popular questions today, was because of you doing palliative care and hospice and dealing with death on almost a daily basis, how do people that mainly work in end-of-life care deal with the emotional toll and damage that can be caused with just seeing so many patients die?
Yeah, that's a really great question. I wish I had like a perfect response for it. But the reality is that, like I said, I don't think it's for everyone. I think you have to be emotionally strong to handle these type of situations. There's a certain personality of people that goes into it. I would say when I was in residency, I noticed that I really liked being with patients with chronic illness and end of life care. I always liked spending time with families. I always took my time explaining things to patients. When I would see these end of life patients, I started, exploring the field of palliative care, and I started doing away rotations. When I was in residency, I actually did an away rotation at NYU, where I ended up doing the fellowship, and at Mount Sinai, to kind of really get a deeper understanding of what this field does. And I realized that a lot of it is pain management and symptom management, and goals of care conversations. So I liked the pain management aspect of it. I didn't want to deal with the pain management for chronic pain patients. I really liked doing pain management for cancer patients. And in my head, I'm like, I'm helping them and helping them make the process of end of life easy as possible and comfortable as possible. So I never think of it as depressing. I always think of it that I'm helping these patients and making these transitions more comfortable, and just kind of understanding that death is a part of life and it's something all of us will experience, but it's important to not cause suffering at the end of it.
Yeah. And you mentioned that, one of the things that you enjoy about hospice care is, working with families, trying to make sure that you can help solve many of the problems that families are going through. And I know currently with the pandemic, a lot of families aren't able to come to hospitals and see their loved ones pass away. So how do protocols change during COVID, and has it made jobs such as hospice care and palliative care just a lot harder?
Yeah, definitely. We always emphasize patients dying next to their loved ones and their loved ones being at their side while they're taking their last breath, so they're able to talk to them. And recently we've incorporated the whole concept of FaceTime, thanks to technology, where loved ones have been FaceTiming and video calling. But before that, it's been so hard. It's been very difficult to deal with, seeing these patients die alone, not surrounded by family, not surrounded by friends, and just by our side. It's been the hardest thing for all medical providers, not just palliative care and hospice physicians. And I don't know what else we could have done differently, because in the end, we also want to make sure when these family members are coming in, they're not getting COVID. We want to make sure that these elderly patients coming in whose family members are dying, we're not making them sick and they're not ending up in the same bed their family members are, so making sure safety is always our top priority. And as difficult as it is, not allowing family members to see the patient, I rather them not see them than them get sick themselves.
Of course.
Or take COVID elsewhere and infect members of the community,
Exactly.
including other people and so on.
And just
Exactly.
spread the pandemic, right? It
Ali,
is difficult, but go ahead.
Ali, one or two more, and then we'll go to the next part.
Oh yeah, of course. So another question is for a lot of people who are, I feel like a good amount of the people, the viewers here, are getting interested about hospice care and palliative care. So they're asking for some helpful skills for interacting with patients and families going through such a stressful time, and some soft skills that any person that wants to be a hospice physician, what they should have if they want to, be a successful hospice physician.
Yeah. So I think one skill I definitely think all physicians in general should have is having empathy. It's so important that, the type of work we do, I always tell all the other physicians that rotate with me, or, physicians I work with, that it's so important to empathize with these patients, and it's so important to empathize with these family members to see where they're coming from, because in the end, it's not about us, it's about them, and it's about their loved one. So I think that's a skill I feel like all physicians and all people going to medicine should have, but also just great communication skills. You should be able to talk to families very openly, not be so emotionally walled off, be able to express, what they're feeling and how they're feeling, and be able to be working with other people, because it's never just me, it's like a team approach, and that team mentality is important in medicine, and no matter what field you go into, especially I'm sure as an ER physician, you're working with so many different consultants and so many different providers, and having a team mentality is so important because you're not going to be doing everything on your own, and you have to know when to involve the right people.
Well, Shanine, we're going to move to the next half now. Do you want to get up for a minute or get a sip of water, or are you doing okay? You've had a long day already.
I'm okay.
All right.
All right. It's all yours.
All right. So now I want to talk about how to deal with the patient's death. We're just going to change gears. We have like 5 more minutes. So now I'm just going to switch scenarios. Let's say you are a resident on call, because a lot of times patients die in the middle of the night. And you are notified by the nurse that Mrs. Smith, this patient, has died at 2 a.m. You are called to pronounce her and do a death exam. So prior to the death confirmation, you want to make sure, let's say if you don't know the patient well, what you would be doing as a resident on call is checking this patient's resuscitation status. You want to make sure she's either full code or DNR, DNI. Do you need to code her or do you not need to code her? Make sure that, you're reviewing the patient's chart. You're not blindly walking into someone's room. You have like a basic, even a one-line understanding of what is it that this patient is here for, the patient's name, their age. Walking into the patient's room, make sure you're introducing yourself. You don't want to be someone that just walks in and starts, doing things to the patient. And if there's like a family member at bedside, you're not even introducing them or introducing yourself to like the medical team that's by the patient's bedside. So these are just basic procedures you do prior to walking into the patient's room. And then, you've been notified the patient has died. And then what you're doing is a death exam. So what we do usually during a death exam in an ICU or inpatient setting is that, we, in COVID age, you're making sure you're gowned with PPE and you're taking the patient's wristband to make sure you have the right patient that you're about to pronounce. You're, just evaluating them for basic signs of life. You're just looking at them to see if they have any respiratory effort. You're calling their name, you're saying hello if they're responding to you. Obviously if they're responding to hello, they're not dead, but these basic things just need to happen before you do like a detailed exam. And then you're checking their pupillary reflex. After death, pupils tend to become fixed and dilated. So you're checking for those like eyes, and you're palpating their carotid artery to make sure that, it's not pulsating. So a lot of times we're getting an EKG strip that shows asystole, a flat line. And then, you remove your PPE. Sometimes in an ICU setting, we do these things called apnea tests, where we see if there's any breathing movement when the ventilator is turned off. So there are all these tests that we do. So next, I just want to talk about that death is a very normal part of life. Doesn't mean it makes it any easier. Seeing a patient die is something all medical providers, whether you're a med student, nurse, or physician, will go through and experience during their career. But it's important to deal with it in a healthy manner. So you want to make sure you're expressing your emotions, especially if you've gotten close to this patient. When I'm on hospital service, I'm seeing them for 7 days straight. You get close to them, I'm there for 12 hours a day with these patients sometimes, and you're getting to know them, you're getting to know their family. Their family is showing you pictures on how they used to be and how they used to look, and you're meeting their kids and their grandkids and this and that, and you're getting close to them as a human. And it's important, and it's important to understand that that's hard. See, now this person doesn't exist, and you just have to pronounce them, and they've died. And so it's important to talk to people. It's important to talk to your colleagues that will be going through similar experiences. Talk to your, friends and family if they're able to understand, and just express your emotions. Also take some time to reflect, that you just saw a human lose their life. And so that's not easy. I always give book recommendations. I always tell patient or people going into medicine in general that it's not just important to read, organic chemistry and basic sciences, but it's also important to read the human aspect of medicine. Like I always recommend Atul Gawande's Being Mortal, that talks about, end of life care. And there's so many other books out there that discuss, the humanity of medicine and dealing with patients' death and things like that, because that's what makes medicine humane. Dispel any feelings of failure. You don't control who gets cancer. You don't control who dies. It's not your fault, and it's really important to understand that, if something happens, you are able to understand that you as a physician or as a practitioner did everything on your end, and it's not your fault. And if things get hard, speak to a licensed therapist. If you start feeling like you are unable to eat, you're unable to sleep, your relationships are being impacted, your mental health is being impacted, it's very important to see a licensed therapist, because if you're unable to take care of yourself mentally and physically, you're not going to be able to take care of your patients. And then last slide, I would say advice for medical students going into medicine. I would always say just get a mentor, do these shadowing sessions. You never know what you want to do till you actually do it. So it's so important to do these type of shadowing sessions, especially now during the pandemic. We're unable to do it in person, so do it online. Just listen to as many physicians talk about their field and talk about cases to get an understanding. Volunteer, all of us go into medicine to help people. So most medical school applicants, I'm sure, you are able to say it better than anyone else. You want to make sure that you're showing that you want to help people and you want to volunteer. Apply early, get involved in extracurricular activities. It's so important to be well-rounded, and most importantly, be humble, be kind. Patients like doctors that are nice and kind and able to show that they empathize and care for them instead of, just someone that's a little robotic. So that's it.
Yeah, that was an incredible presentation today, Dr. Lalani. We're going to ask a couple more questions if you're okay with that.
Sure.
All right. So we know that for hospice patients, it's usually for people that have 6 months or less to live for the most part. But what happens if a hospice patient is still alive after that 6-month time period? Let's say like 7 or 8 months later, they're still alive. What do you guys do then?
So what we usually do is we often evaluate the hospice patient every 3 months to see if they qualify for hospice again. Some patients stay on hospice for a year, so they can always re-qualify for it. Because just because we say they have 6 months or less to live doesn't mean everyone dies in that exact time frame. Sometimes patients take longer. There are times patients graduate from hospice. We love seeing that, where they no longer need hospice and miraculously something has happened where their disease has progressed in a way that no one could have predicted. And so that's always good news. But a lot of times we just renew them for the next cycle.
Yeah. Another question that we got was when you're talking a little bit about opioids, we were just, some of the people on the chat were just wondering, how do you balance prescribing opioids and adjusting patients' requests to be cognitively present? So like not drowsy, absent during the day, and what do you do if you see there's some patterns of addiction for your patients? Would you still prescribe opioids, or what would be another track for you when it comes to pain medication?
Those are very great questions. So our philosophy is always to start low and then eventually slowly increase. So the dosage we're giving in the beginning, we carefully assess, whether it is outpatient or inpatient setting, that the patient is not becoming too drowsy, the patient is able to converse, they're not absent. And with the lowest dosage we give them, then we titrate them up. So usually in an outpatient, there's a lot of palliative care outpatient clinics as well. So when patients see us in the outpatient setting, we're doing a very close follow-up. We often, when we first prescribe them opioids, see them every week or 2 weeks to see, how was the new dose, and then their body adjusts to a dose. So we're the goal is always to not give too much where they're not able to function, but to just give enough to where their functional status improves. So they're able to kind of do certain things they are not able to do because they were in pain. So starting low is truly the key, and having a very close follow-up. Addiction is something that we are constantly looking out for. It's not something you can predict sometimes in patients, but there's certain tools that we use to see if are the patients getting addicted, are there family members that might be using it. What we usually do is a pill count. So we don't prescribe opioids for like 30 days. We usually prescribe them for like a week or 2 weeks. And that's very important in us to assess, like if I prescribed you 5 milligrams of morphine every 6 hours, that's that many pills. When you come visit me and you're telling me that you only used 2 pills a day, how many pills do you have left? This many were dispensed. So we often do a very strict pill count in an outpatient setting, to see if anyone is misusing or taking too much. We take a very detailed, thorough pain history. If the patient says, like, I wasn't able to do this, but I'm able to do this now and sleep comfortably, then that means the opioids are working and we don't need to go higher on the dose. The goal is never, we always tell them that the goal is never to make your pain zero. The goal is to make your pain tolerable to where you're able to do certain activities.
Maybe one more, Ali.
One more? Okay.
Yeah, just one.
All right. So let me see. Got a lot of good ones, so it's kind of hard to pick a final one, but all right, we can do this one. So what sorts of procedures are in place to help grieving family and friends after a patient passes away?
So if when we work in a hospice setting, there is a team of providers, especially social workers, that have grieving services. What we do in outpatient hospice settings is the social worker often calls the family when the patient passes away. We offer services like grief counselors, and then we call them every 3 months and sometimes 6 months to follow up with them to see if, how are they dealing with what's going on? Do more social workers need to get involved? Is there anything they need? Those services are not available all the time to all the patients, depending on the state they're in. And personally, I think better services are needed in that area to help families. And there's not that much out there right now.
Shanine Lalani, what a wonderful, moving talk you gave to us this evening. I had to reach for a handkerchief a couple times.
Yeah.
Well, just reliving a long life in medicine, and how many times I've been at the bedside watching people who've either not made decisions about how to manage the end of their lives, or the flip side of that, where there have been folks who've been, taken to the very end. And I had the honor of being present, as you have been present, for so many people as they face that end that we all wonder about. Shanine will post this online, and probably 5,000 students will watch it, and each one of them will become a healthcare provider on their own. And in a career, they will probably see 100,000 patients. 5,000 times 100,000 is 500 million. With this wonderful talk you've given tonight, Shanine, you have touched or will have touched 500 million lives. And I think all of us as healthcare providers would just think that that's a wonderful opportunity to be able to touch so many people. Let me ask all the students to please say thank you, Dr. Lalani, and put it in chat so she can see the hundreds of thank yous come pouring in. And there it is. I hope you can see it, Shanine. So very much appreciated. Shanine, could you flip to the next slide, please?
Sure.
And Ali, you want to talk about the session?
Yeah, I'd love to.
The quiz?
Right. So right here is a QR code for today's quiz. It's going to be due by next Tuesday at 6:59 p.m. Central Standard Time. You guys are going to get 2 attempts on it, and make sure you score above a 70, because if you do so, you'll get a certificate for attendance to show that you were here, and you get the 2 hours of shadowing. Another thing is that one of our guys in the working group, Aditya, has been so kind to posted the links for the quiz for session 10. Make sure you guys find that in the chat. Aditya just posted it again. You guys can access this quiz, and you can get credit hours if you haven't already gotten hours for session 10. So an extra 2 hours is just great. So highly recommend you guys do that. Other than that, I think I'm done from my part. Dr. Val, you want to end up?
Yeah, and Shanine, thank you again so much for joining us.
Thank you so much, Dr. Lalani.
This has been a terrific session. We're so grateful to you. We have a wonderful session. Thank you again, Shanine. We have a marvelous session coming up next week with Dr. Preston Bloomquist, ophthalmologist, lovely guy, such a nice man that I worked with for years on the admissions committee. And we'll talk about the admissions process quite a bit next week as well. Well, so we wrap up another session. Dr. Lalani, again, thank you for coming.
Yeah, if you
And
guys
for
have
all,
any questions, you can always reach out to me through IG. I try my best to answer as many questions as possible. It's obviously really hard when it's a lot of people, but thank you so much for
Your
having
handles on the
me.
chat as well.
and thank you again, Dr. Lalani. And so on behalf of the whole working group, we're gonna be here if you keep coming back. So we want to thank you. We did have something happen, Janine, during your talk. We actually crossed 61,000 people signed up on our website for virtual shadowing right during your talk. So that was kind of fun. And so we're just awfully honored and flattered that so many of you keep coming back week after week. Well, on behalf of the whole virtual shadowing working group and Dr. Lalani and all the wonderful speakers that we have, we want to thank you for coming. We'll keep being here week after week if you keep coming. So on behalf of the whole team, we want to wish you a good